Good morning. I'm Richard Oehler, infectious disease practitioner and associate professor at the James A. Haley Veterans Hospital and the University of South Florida in Tampa. And today I'm going to talk to you about what to do with a positive blood culture. Bacteremia and positive blood cultures are a significant source of some uncertainty and difficulty with management decisions as we take care of patients in the hospital. My goal today is to discuss some of the nuances in treating positive blood cultures from the point you are called to when you have to decide how to manage these cases. Many of you may intuitively agree that blood cultures are among the most commonly ordered laboratory tests. Blood culture positivity occurs fairly often. In a prior series, approximately 9.7% of blood cultures were positive. And there's been a trend in blood culture positivity that has occurred over the last several decades. Whereas gram-negative organisms were once the most predominant pathogens in hospital-acquired bacteremia, over the last couple of decades, due to the increased use of implanted devices such as cardiovascular devices, indwelling lines, and so forth, gram-positives now predominate. Coagulase negative Staphylococcus is the most commonly isolated pathogen in the present day, about 24% of positive blood cultures. Not just the treatment, but the financial impacts of positive blood cultures are profound. Recent data suggests that the mean infection-related cost in a recent study was about $67,000 for patients with hospital-acquired Staph aureus bacteremia, one of the most common, of course, and somewhat less, but certainly not an insignificant amount, about $37,000 or $38,000 for community-acquired Staph aureus bacteremia. Part of the considerable cost relates to the fact that positive blood cultures can extend length of stay in hospitalized patients by a mean of 4 days or longer. And what's more, MRSA bacteremia is now part of the hospital-acquired conditions reporting program that ties bacteremia and central line-associated bloodstream infections to hospital reimbursement. Positive blood cultures can have other impacts as well. They can cancel surgical and procedural schedules. They can affect device and line placements and explantations. They lead to considerable costs related to antimicrobial therapy and can increase the financial cost for infection control programs and so forth. Now, don't let anyone tell you to the contrary. Blood culture collection techniques do matter, and they do affect contamination rates strongly. At our facility, for example, contamination rates are tracked and reported for quality improvement purposes. Contamination rates tend to average about 2 to 3%, and typical organisms seen include coagulase negative Staphylococci, Corynebacterium, Bacillus, Propionibacterium, and Micrococcus. Now, many blood cultures are collected in the emergency department, and although this is an area where a high proportion of blood cultures are collected, as we have stated, it also happens to be a less than ideal collection spot. The reasons are known to many of us, and they include time and treatment pressures, where providers and blood culture collectors are encouraged to rapidly collect specimens. Patients, in many cases, are coming right from less than ideal conditions where their skin may be contaminated, and because of the high volume that occurs there, there isn't always the most strict application of sterile collection techniques. The antecubital fossa is a common site for the collection of blood cultures, and typical blood culture collection techniques are shown here. These are Bactec bottles, which we use in our institution, and typically a blood culture bottle may be filled using a butterfly technique. A lot of the sterility of blood culture collection involves skin preparation, and when you have a young patient with healthy veins and good skin consistency, sterile technique can be maximized. But many of our patients have vascular fragility, have very thin skin or poor veins, and this may require multiple collection technique, multiple collection attempts to try to get the vessel cannulated. Unfortunately, these collection techniques do not hold up as well when patients require blood culture collection in other areas that are less than ideal, such as the dorsum of the hand. We've even seen blood cultures being collected from, for instance, pedal veins and other areas on the arm, or extremities where conditions are not ideal, and skin prep cannot, unfortunately, eliminate some of the contamination that may occur. Now, back in the day when I started my education as an infectious disease fellow, blood culture systems were, in many cases, manual. They involved standard inoculation of blood culture bottles and incubation in a incubator that was observed, and the blood culture racks were pulled out a couple of times a day, and then microbiology techs would examine the bottles for evidence of flocculation or sediment within the bottles that could be a sign of a positive blood culture. Those would be aspirated and gram stained, and if the gram stain was positive, then the blood culture would be called a positive culture. And for this reason, blood culture results were only announced a couple of times a day. Usually there were morning and afternoon blood culture interpretations, and that's when you would get called. But in recent years, automated blood culture systems have been much more readily available, and almost every institution uses an automated system. The advantages are obvious. By having a fully automated system, you can have continuous monitoring of the blood culture bottles, rapid detection, so that blood cultures are not called out just twice a day, but in fact, any time that they are detected as positive. They're more reliable because the automated interpretation system is much more sensitive and more foolproof. They permit high volume testing, and human error is minimized because there's no human interpretation as part of the initial step. The estimated cost of each blood culture bottle is about $75 to $150. So this is not cheap, but it is relatively modestly priced compared with the cost of many other laboratory assays, including some of the DNA or genetic-based assays. So how does the clinician assess initially a positive blood culture? Well, first of all, the information you'll generally get from the microbiology technician is the results of the initial gram stain. Again, when an automated blood culture bottle is read, it's usually read via a colorimetric technique. On the bottom of the bottle is a color disc, and this disc changes color when there's microbial growth within the bottle. The machine reads the bottle, and when the colorimetric change reaches a certain threshold, the blood culture is flagged as being positive. The microbiology technician then aspirates from the bottle and gram stains the result. So the initial blood culture result that you recall being called about is the gram stain results. Is this a gram-positive cocci, a gram-positive rod, a gram-negative cocci, or a gram-negative rod? And you also want to hear whether the blood culture is called from a single bottle versus multiple bottles. Now, each blood culture draw is involves a collection of an aerobic or anaerobic bottle. So typically when we order blood cultures times 2 sets, we get 4 bottles. So as the clinician receiving these results, you want to know how many of these bottles, of these 4 bottles, are positive. The next thing you want to know is what the collection source is. And unfortunately, though we try otherwise, most bottles are not labeled. It particularly helps to hear about the collection site and whether this involves a peripheral blood culture collection versus a collection via a central line or midline. And sometimes determining the source may require further investigation. By that I mean you may need to go and talk with the patient and say, hello, Mr. Jones, do you recall when you had a large sample of blood put into a bottle that looks like one of those liquor bottles from an airline? Do you remember where they collected it from? That can help you determine whether a blood culture bottle was collected from a central or peripheral source. And sometimes this is documented in the patient's chart. It just requires a little bit of looking into. And we should always encourage our blood culture collectors to label the bottles. Unfortunately, what I think most of us know intuitively is that phlebotomists as a trade, phlebotomy has rapid turnover. So there's a constant struggle to make sure that phlebotomists are educated and trained to collect blood cultures in a sterile way. Now, does the time from collection to positivity matter? Well, there's a blood culture standard called DTP, or differential time to positivity. This can often help you determine how reliable a blood culture result is. The DTP states that growth detected from a catheter hub sample at least 2 hours before growth from a peripheral blood sample is highly indicative of a positive blood culture secondary to a central line. So if you see a growth from a catheter hub sample at least 2 hours before growth from a peripheral blood sample, it has a high correlation to a central line infection. So that's one metric that we go by. What are some intrinsic risk factors for nosocomial bloodstream infections? Chronic illness is such a risk factor, particularly in patients who have multiple comorbidities. Patients with weakened immune system, including those who have stem cell transplantation, and those with prolonged neutropenia, especially those with high-grade neutropenia, less than 100 cells. Hematologic tumors have a greater risk of nosocomial bloodstream infections than solid tumors. And you also have to consider those who are malnourished. Patients on TPN, they can be susceptible to bloodstream infections, particularly to yeasts such as Candida parapsilosis. Having a prior bloodstream infection history is also a risk factor, and we do see more bloodstream infections in the extremes of age. Lastly, patients with burns, those with other sources of compromised skin integrity such as Stevens-Johnson syndrome, toxic epidermal necrolysis, or other conditions can be susceptible. And lastly, those with other mucosal barrier injury, such as we have said, prolonged neutropenics, or those with injuries of the GI mucosa can develop bloodstream infections. What are some secondary risk factors for having a positive blood culture? Well, again, we've said if blood culture collection techniques are not ideal, positive blood cultures, false positive blood cultures can occur. Prior history of bacteremia, as we've shown, also a risk factor, and the presence of medical devices. Nowadays, we are seeing a far greater percentage of patients who have an implanted ICD or pacer. Of course, those with central venous access, and patients with prosthetic devices such as prosthetic joints or other implanted devices such as baclofen pumps. As I've said before, the skin condition of the patient is vital. If you see a patient with very thin skin and vascular fragility and poor veins, chances are the phlebotomist is going to have needed to cannulate the patient's, to attempt to cannulate the patient's highly non-ideal veins in order to get an adequate sample. And as I've said before, interruption of mucosal barriers, particularly the loss of fibronectin, is thought to play a significant role. So what characteristics increase the likelihood that a blood culture is a false positive? Well, as we talked about time to culture positivity, if we see prolonged time to culture positivity, for example, the growth of a Staphylococcus epidermidis after 3 days from when a blood culture is collected, that tends to be correlated with a false positive blood culture. Polymicrobial growth of bacteria versus monomicrobial. If you see Staph epi, for instance, E. coli, and Strep viridans in a blood culture versus just the pure growth of Staph aureus, for instance, that polymicrobial culture is more likely to be a contaminant. In addition, and I'll elaborate on this in just a moment, the presence of certain bacterial strains are more likely to be associated with contamination. And also the lack of systemic symptoms that are associated with bacteremia. Again, there are certain strains that in the presence of indwelling lines, one must exercise caution in terms of interpreting them as a positive result. So what blood culture pathogens are frequent contaminants? I've listed some of them here. Coagulase negative staphylococci, I think many of us will recognize as a frequent blood culture contaminant. Corynebacterium species, although as I will mention, there is a Corynebacterium species, Corynebacterium jkm, that may be significant in the presence of indwelling lines. Bacillus species, also a contaminant, and same caveat applies in the presence of certain indwelling lines. Propionibacterium species, a frequent contaminant. Micrococcus. Viridin streptococci, interesting to put it on this list. I'll elaborate in just a minute, as well as Enterococci and Clostridium perfringens. Clostridium perfringens appears on this list, but again, it can also be a pathogen as well. So interpretation of other factors is important to determine. For example, a patient with a crush injury or sepsis, Clostridium perfringens would be significant. And I've listed 3 of these pathogens, particularly Corynebacterium, Bacillus, and Propionibacterium, as being particularly associated with blood culture contamination. So what characteristics define a true positive blood culture? Well, as I've said before, the presence of a single pathogen typically associated with bacteremia, such as Staph aureus or Enterococcus faecalis, is more significant than multiple pathogens. Pathogens typically consistent with blood culture organisms include Staph aureus, Streptococci, Enterococci, Gram-negative rods, and so forth. Multiple positive cultures with the same pathogen, especially over an interval of time, are significant. So if you see the presence of Streptococcus viridans over a time period of 12 hours where 2 or 3 blood culture samples were obtained at different times, that's significant. And also, you have to ask yourself, does the patient have clinical symptoms consistent with bacteremia, such as fever or septicemia? Lastly, does the patient have other bacteremia risk factors, such as an intravascular catheter or an obvious GU respiratory or vascular source? These blood culture pathogens are not usually or never contaminants. So when you see these in a blood culture, you want to apply your clinical acumen, but you want to be especially suspicious. Obviously, among the gram-positive or fungal pathogens, Staphylococcus aureus is a big one. Streptococcus pyogenes, Streptococcus agalactiae, Strep pneumo, as well as Clostridium, Listeria, Candida, or Cryptococcus species. Gram-negatives that are usually never contaminants. And I would say, in general, gram-negative bacilli are less often, as a class, blood culture contaminants in comparison to gram-positives. But you want to think about the Enterobacteriaceae, Pseudomonas aeruginosa, H. flu, Neisseria, gonorrhea, meningitis, and Bacteroides. So when you assess a true positive blood culture, you want to ask yourself the following questions. Are blood culture results consistent with bacteremia? Is the patient symptomatic? And does the patient have risk factors? For non-hospitalized patients, risk factors include cellulitis, type 2 diabetes or the presence of a diabetic ulcer. GI infection can also produce bacteremia. We think about Clostridium difficile, for example, or other infections that affect the mucosal barrier. We also want to consider metastatic foci associated with bacteremia, such as patients who may be complaining of low back pain, who may have discitis, or patients with osteomyelitis, particularly of the lower extremities. And we see a high correlation in those with renal failure and diabetes. Patients with cardiovascular devices such as ICDs or pacemakers. And we never want to miss a case of occult community-acquired endocarditis in a patient spontaneously presenting from the community that has a Staph aureus or MSSA bacteremia, for example. For hospitalized patients, we want to think about central line devices such as triple lumens, patients with metaports, those with implanted tunnel catheters such as Hickman's or Gershong's, patients with PICC lines, particularly those in which the PICC line has been in place for several weeks or several months, and we should not eliminate the possibility of a bacteremia secondary to ART lines. We also want to consider GU catheters, patients with healthcare-associated pneumonia, those with surgical wound infections, as well as those with other implanted devices. Let's talk about some select gram-positive pathogens of significance. Staphylococcus epidermidis. Again, when we see this pathogen in a blood culture, number one, we have to ask ourselves, how many blood culture bottles are positive? Because if you have a single blood culture bottle positive of 4 in a standard blood cultures times 2 collection, that's often a contaminant. But on the other hand, if you have 4 out of 4 bottles positive for Staphylococcus epidermidis in a symptomatic patient who has risk factors for bacteremia such as an indwelling catheter, you want to definitely consider that much more likely to be a true pathogen and a true bacteremia. Staphylococcus aureus is almost never considered to be a contaminant, and we want to draw a distinction between MSSA and MRSA in terms of treatment. We've said that viridin streptococci can be a contaminant, but because they are also endocarditis pathogens, we have to take them seriously, especially in patients who have risk factors for bacteremia. So Streptococcus viridins, viridin streptococci, which include mitis, mutans, and so forth, they're significant in that they can be endocarditis pathogens, but they can also be contaminants. And Enterococcus species, and those with a genitourinary source or an indwelling device, are of significance, and we want to consider Enterococcus fecalis, which is more susceptible but tends to be more of higher virulence than Enterococcus faecium or VRE. And lastly, Corynebacterium bacillus in the presence of an indwelling device may be significant, and Listeria is never a contaminant. And we must always rule out meningitis or complicated infections due to Listeria. Gram-negative pathogens of significance, we want to think about the Enterobacteriaceae like E. coli, Klebsiella, or the carbapenemase producing Enterobacteriaceae, or the CREs. Proteus, Providentia, and Serratia, when these are present, we always want to rule out a genitourinary source or a hospital-acquired source. Pseudomonas bacteremia is a serious bacteremia that needs to be addressed quickly. Patients can have risk factors secondary to a genitourinary source, indwelling devices, and so forth. Surgical wounds are also significant. And Acinetobacter and Stenotrophomonas are often seen in patients with environmental contamination or those who have been heavily antibiotic experienced. What are so-called sentinel bacteremias? When we see these pathogens in a blood culture result, they should definitely raise alarm for different reasons. Again, for Clostridium species, we want to rule out a GI source, particularly GI malignancies. So if you see a Clostridium septicum, for example, we want to think about a GI source, occasionally gallbladder. Also have to consider GI malignancies. Streptococcus galolyticus used to be known as strep bovis, and this is strongly correlated with lower GI tract malignancies. Burkholderia. Again, Burkholderia positive blood cultures are important because there are 2 species of Burkholderia that are typically seen. Burkholderia pseudomallei, which causes melioidosis, versus Burkholderia cepacia, which can be a hospital-acquired pathogen. You do not want to miss a case of melioidosis due to Burkholderia pseudomallei, and that's why whenever a blood culture is positive for Burkholderia, you want to ask for a species differentiation. Listeria, as a positive blood culture, you want to think about Listeria meningitis and also Listeria related to perhaps vascular procedures, bacteremia secondary to a GI tract source in an immunocompromised or pregnant patient. So when we assess and manage a positive blood culture, we want to determine if it's a true bacteremia versus contaminant. So what if we suspect that a blood culture is a contaminant? We want to assess if there's reasons for contamination. Does a patient have poor skin integrity or problems with hygiene? Did they have these factors at the time their original blood culture was collected? Was blood culture collection techniques, were they compromised? And as I said, the lab publishes their blood culture contamination rates on a monthly basis. So we want to be aware of whether there's a historical basis to suspect blood culture collection problems. We also want to document risk factors, and in the right situation, we want to consider repeat blood cultures. For instance, someone with a positive blood culture for Staph epidermidis in 1 out of 4 bottles, let's say they're symptomatic, we want to consider repeating the blood cultures, particularly off of antibiotics, to see if we can duplicate the original result. If we strongly suspect that a blood culture is a true positive blood culture, we want to assess for sources. We want to look for indwelling devices, a skin or soft tissue source, a GI or GU process, and the presence of any other septic foci. Secondly, we want to determine the need for treatment. We know intuitively that gram-negative endotoxemia has the highest acute mortality, and that's why these patients require rapid antimicrobial therapy. And although Staphylococcus aureus bacteremia may have a somewhat lower overall mortality, a somewhat lower acute mortality, it tends to have the greatest overall mortality. It's a sticky pathogen. It complicates device-related with device-related infections, and is a high endocarditis risk for patients with Staph aureus bacteremia. Pseudomonas aeruginosa also has very high morbidity from infection and must be treated aggressively as a gram-negative pathogen. Third, you want to address the underlying focus. You want to debride any infected wounds, debulk cases of osteomyelitis or discitis. We want to remove infected devices if they're present, such as indwelling lines, implanted cardiovascular devices, or prosthetic joints. We want to rule out septic thrombophlebitis, particularly in our patients who present with persistent bacteremia despite the removal of a suspected infected catheter. And we want to rule out an endovascular focus. If we have a blood culture that's positive for a pathogen that can produce endocarditis, we want to screen patients for the possibility of an endocarditis being present. And lastly, we want to promptly begin antibiotic treatment. Some pathogens are more antibiotic critical, and as we said, gram-negative pathogens, Staphylococcus aureus, Pseudomonas, are all pathogens where you want to be fairly aggressive with rapid initiation of therapy. What are some basic principles for antibiotic treatment? Broad-spectrum antibiotic therapy may be necessary until you get specific identification returned on your blood culture result. So if we just get a positive blood culture that's called for a gram-negative rod, unfortunately, we may need to start broad-spectrum antibiotic therapy until we can have further results available. Once blood culture results are available, we want to tailor our antibiotic therapy to the specific pathogen if possible. You want to use pharmacokinetics to your advantage, and we want to be aware of antimicrobial classes that work better for bacteremia. And some antimicrobial classes are preferred in bacteremia more so than others. The good, as I identify them, include glycopeptides such as vancomycin, daptomycin, both for gram-positives, beta-lactams and carbapenems for gram-negatives, and aminoglycosides in particular for gram-negatives. Less than ideal choices might be quinolones. Although these are good for certain enteric bacteremias, quinolones in general don't have the bacteremia clearance capability of some of the antibiotics I've identified on my good list. Tetracyclines, particularly tigecycline, again, in terms of intravascular levels, they don't excel as much as, let's say, beta-lactams, for instance. trimethoprim sulfa and the oxazolidinones also. Probably not first-line choices for bacteremia, but may have utility in some select circumstances. You want to determine the necessary duration of therapy, and this is usually calculated from when we document blood culture clearance. So repeat blood cultures after a bacteremia are always critical because they allow us to document clearance of the bacteremia and to set the start date of our treatment duration. And of course, pathogen-specific factors apply. So what are some pathogen-specific factors? Well, pneumococcal bacteremia, although it can have high morbidity, is highly antibiotic responsive and only requires a short duration of antimicrobial therapy. Enteric bacteria, typically we treat these for 2 weeks, and we want to consider aminoglycosides as part of initial therapy. Pseudomonas species, typically a 2-week minimum is required. IV antibiotic therapy is preferred, and as it is a potential endovascular pathogen, oftentimes we want to screen patients for the possibility of endocarditis. 1 versus 2 drug therapy tends to be controversial for Pseudomonas, but before we have susceptibilities available, it is perfectly appropriate to use 2 drug therapy, for example, a beta-lactam plus an aminoglycoside, until we are sure that the pathogen is susceptible, and then 2 drug therapy can be de-escalated to 1 drug. Endocarditis pathogens such as Staphylococcus species, Viridin streptococci, Enterococcus, typically we treat these for anywhere from 2 to 6 weeks. If endocarditis is present, obviously a 6-week course of therapy is typically recommended. And these endocarditis pathogens should initiate screening for endocarditis with echocardiography. And surgical consultation may be necessary if endocarditis is present, particularly with Staphylococcus aureus, or in cases where echocardiography reveals the potential for significant valve damage or failure. What are some post-treatment considerations for a positive blood culture? We want to make sure we reduce risk factors for recurrent bacteremia. We want to minimize the use of unnecessary lines. We want to eliminate unnecessary implanted devices, such as vascular devices, ICDs, or GU stents. If there's an endovascular source and we have reason to believe that the competency of the valve is compromised, then valve replacement may be necessary, particularly with Staphylococcus aureus bacteremia or Staph aureus endocarditis. And surveillance blood cultures may sometimes be a valuable tool. If we're not sure that a bacteremia has been cleared or we suspect a positive blood culture, ordering repeat blood cultures at some point in the future may allow us to document bacteremia clearance or that original blood cultures were false positives. What are some resources for the clinician that we use to help us with the treatment of positive blood cultures? The Sanford Guide, for those of you who are less familiar with this document, is an outstanding reference. It's kind of an ID clinician in your pocket, and it's available both as an online resource, as a printed resource, and an app. And you can find further information at this link. Many clinicians also swear by the Johns Hopkins Antibiotic Guide, and I've listed the URL here. And lastly, UpToDate is a valuable resource. I particularly like them because UpToDate makes an effort to talk about antibiotic treatment duration. And so if you're unsure how long to treat a bacteremia, you can find a lot of resources at UpToDate. So what to do with a positive blood culture? Here's my summary. The epidemiology of positive blood cultures is profound. Initial assessment of positive blood cultures must include the determination about whether it is a contaminant or a true pathogen. Further assessment of true bacteremia should include the identification of any underlying focus. And treatment of a true bacteremia must include the containment, explantation, or neutralization of any underlying focus in addition to effective antimicrobial therapy. Lastly, post-treatment strategies to prevent a bacteremia recurrence may include surveillance, such as blood cultures and imaging. Surveillance blood cultures or a follow-up echocardiogram is often necessary, a necessary strategy, and can be obtained readily. Well, thank you all very much for listening. I hope I've helped you identify both some initial assessment, evaluation, and management and treatment strategies. I haven't really focused on therapeutics, how to treat different positive blood cultures, because I really felt it was beyond the scope of this talk, but perhaps I'll have a subsequent talk along those lines. And you can find further information about specific treatment approaches for different pathogens in the resources that I mentioned. Thank you all very much, and have a great day.